Medic 12, and 810, Priority 1, MVP with entrapment.
Hey guys, welcome back to the PCHD EMS Podcast. Today we have very special guests, Rusty and Connor, with us, two of our field paramedics. And we're going to be talking about a call that they ran last year. Not the perfect call. Nobody runs a perfect call, but the perfect outcome. Couldn't have had a better outcome. And we're going to kind of highlight some things that we can learn from this. And we're also going to highlight some things that we did really, really well. So, Northeim, do you have anything to say about this call before we get into it? I'm going to ask Rusty and Connor kind of.
No, I think what we learned about body cams is it's not perfection. So if we can take this and learn, and everyone can learn from it. But yes, the outcome is amazing, and they did a great job. And I think the two big highlights are at the end. We'll kind of talk about the two most important things that save lives with cardiac arrest, and they were definitely apparent in this video and the care of this patient.
So first of all, just kind of introduce yourselves, Rusty and Connor. Rusty, if you want to go first, just kind of tell us a little bit about yourselves, and we'll go from there.
Rusty Calhoun. Been employed with the Parker County Hospital District for going on 23 years. Lots of changes over this time, but the improvements have been awesome, especially with adding Best EMS. That's been just phenomenal from where we were 20 years ago to where we are now. It's amazing.
Yeah, I kind of wish I could go first. His is a lot more impressive than mine is. I'm Connor Barnes. I've been a paramedic for 8 years. I've been here for going on 4 now. And like Rusty said, just a great system to be part of. We get a lot of opportunities, a lot of equipment, a lot of training. In fact, some of the stuff that's in this video, we had a training on almost immediately before about conscious CPR. So
that's how it goes.
Yeah, it was great to go. Hey, hang on a second. Nope, we need to stay on that chest. You know, we just got that refresher. Yeah,
that's why we don't train on OB deliveries all the time.
Right? Yeah, it's bad luck. Put it in the ether.
So, whose call was it?
That was my call.
Okay. So Connor, why don't you just tell us a little bit about the call dispatch information and what you were thinking on the way to the call?
So we were in Springtown. That's our busiest part of the county to be in, like per capita. So I don't know how many we ran that day, but it's fair to say more than a handful. It was just your regular priority 2 chest pain. I think the caller ended up wanting to cancel the ambulance, thinking, oh no, I'll just hop in the shower, maybe the chest pain will get better.
Oh wow.
And our dispatcher Marita talked him into letting the ambulance roll.
That's huge.
Absolutely huge. Massive, yeah. So there was really nothing special at all going into it. Nothing that was raising any flags. It was just another, I don't know if it was a Tuesday, but
so it was dispatched out emergent, just regular chest pain, nothing special.
Mm-hmm.
Okay.
She even said Marina played a vital part in this because he said just cancel it, and she said, well, since they're already on their way, just let them come and check you out anyway, just because it would have been a great different outcome.
Oh yeah,
a huge different outcome.
Unwitnessed arrest is not great.
With no one else home.
And nobody home. Yeah.
Especially in a large county.
Mm-hmm.
Yep. Yeah. There was nobody home.
That's probably a call we get a couple days later. So that's good. All right, I'm going to go ahead and start playing the video.
Okay. Parker County EMS, what's the address of the emergency? And tell me exactly what happened.
My chest is hurting and my jaw's hurting. I don't know. I may be overreacting, but.
Okay. Are you alone right now?
Yeah, I am.
Okay. How old are you?
59.
Okay. Hang on one sec. I've already got him on the way. I've just got some more questions for you. Okay.
Okay.
Is your breathing normal for you?
I think so. Yeah,
okay.
I think so. It's just my jaw's been hurting, and now it's in my chest.
Okay. Are you clammy or having cold sweats?
I am a little clammy, yeah.
Okay. Have you ever had a heart attack or angina?
I have not.
Howdy, sir. I'm okay. How are you?
Chest is hurting.
Okay. Well, let's get you looked at here. What's your name?
Terry.
Terry? Back problems a patient. All right, Terry. My name's Connor.
Okay.
Okay. So how long you been having chest pain for?
Just about 45 minutes or so. I thought maybe go away.
Okay. What were you doing over at Starbucks?
Just watching TV.
Okay. No activity or nothing?
No, I haven't done anything really.
Okay. You ever had chest pain like this before?
No.
Okay. How long you been sweating like this?
Just started.
Okay. What type of medical problems do you have?
High blood pressure, some, not bad though.
Okay. Take medicine for it?
Yes, I just took it a minute ago. I take it every morning. I didn't this morning.
Okay. Alrighty. Are you allergic to any medicines?
No, as I know of.
All right. Well, we're gonna take a picture of your heart real quick. Are we run low? Yeah. Okay. All right. And what's the pain feel like, would you say?
I don't know really. I've never felt it. It just hurts in my chest and my jaw.
Okay.
Had you ever had heart attacks before or anything?
No,
But
just
any
high blood
feel
pressure.
any, like specifically sharp or dull or nothing? You can't land on anything for that?
No, just constant. It hurts.
Okay.
How long you been sweating? Just like 5 minutes.
Yeah, you said it started about the same time as pain did. Oh, there we go.
I remember telling Connor that when we walked later on, that when you could tell he was having a heart attack when we walked in the door, just looking at him.
How far away are you guys from the cath lab?
30 minutes.
You guys go to
17 miles.
All right.
Close your eyes. Your heart does do your chest too, so that's why I got it. Yeah.
You might get in the way. Go ahead. The razor out of the back.
You can't make yourself sweat, right? So
Just in
there's
time for
something
beach
else going
season.
on here.
Put a little smiley face. You can do it.
I got it. Should be enough. Okay. You ever had heart problems before?
No.
Okay.
Sorry.
Well, we'll see what the almighty machine says when we get this picture of your heart here.
How old are you?
59.
59? All right, would you be still for me?
So just roughly EKG within about 2 minutes from patient contact.
Oh, that's fantastic.
Yeah, that'll help. Yeah, so I'm just gonna let it settle. Okay. Yes, sir.
You been working outside?
No, yesterday.
Is that when you saw it?
Yeah.
Okay.
There was no doubt.
Well, Terry, I got good news and bad news for you. The good news is it hasn't been going on for very long. Bad news is this looks a lot like a heart attack, okay? So I don't say that to scare you, but it'd be a little wrong, I'll tell you what's going on, right? So
I'm going to pause it real quick. I'm going to go ahead and pull up the I'm going to pull up the 12 lead so we can all look at it real quick.
So you can marvel at my 12 lead interpretation.
I don't know if this was actually I don't know if this was your first one or not.
That's 12 lead 3.
Okay. This is one of the ones that I pulled from the chart.
They all looked about like that.
That's a STEMI.
Yeah.
Strong work.
Interceptal, we got ST depression inferiorly, kind of driving it home. Got a big one.
So is there anything else inside the house that we really need to watch, or should we just go to the, what do you think?
Just I would hit on his blood pressure.
Okay.
I can't
What is his blood pressure here?
I think it's 130s over 80s. It's
Okay.
His
So
blood
let's-
pressure was fine while he was conscious.
Yeah.
And
Let me go
then
back here real quick.
immediately upon basically crossing the threshold of his front door is when he started vomiting.
So nausea, jaw pain, chest pain, sweaty.
Textbook.
Yep.
No history.
Other than high blood pressure.
Yeah.
Right?
You been working outside?
No, yesterday. Not today.
Okay.
When did he say the chest pain started?
45 minutes ago.
Well, Terry, I got good news and bad news for you. The good news is it hasn't been going on for very
That
long.
is a unique way of
Bad
telling
news
somebody
is
to have a
this
heart
looks a
attack.
lot like a heart attack.
I'm a unique guy.
Yeah.
So I don't say that to scare you, but it'd be a little wrong. I'll tell you what's going on, right? So we're gonna get you up on the stretcher here, and we'll be taking you to the hospital in Weatherford. Okay?
So I'll do that. I'm gonna do that.
Yep, sounds good. We'll get them out to you.
All right. Have you been dizzy or anything?
No, just kind of my jaw started hurting. I got a headache.
Sure.
And then this, after I called you, I was going to go start hurting.
Okay. Am I moving this with you here? Nice.
So Rusty, you went out to the truck to set up an IV, right?
Yes.
Yeah.
We kind of do that. He
Saves
does
a
it
little
on
bit of
my
time.
calls. I do it on his calls. If we got something that would save time,
Absolutely.
we try to do that. It's just something we've been doing together. So
Yeah.
I feel like I'm going to get sick.
Okay. We'll give you some medicine for that. Okay. That's not uncommon for something going on. All right. Your phone's in between your legs there.
Feel cold? You feel nauseous?
There should be one on the back there. Yeah.
Okay, so you guys are
I'm gonna swap out.
in the ambulance now. Rusty, you're starting an IV.
The ambulance camera actually does a little better job showing his pallor, that color of
Yeah.
him against the cot there.
Yeah.
So he's already filled that one up.
Yeah, Rusty, whenever you're done with that, I'm ready to go. Yeah, we're looking pretty okay. I think. Alrighty.
I didn't know yet.
Jinx yourself there. We're looking
I don't think
okay.
about eating much, but can you chew up some medicine for me?
Yeah, sure. Yeah.
Okay. Can we just drop them in your mouth
Yeah,
for you?
that's
Okay, just chew these up and eat them. They're orange flavored. That's some aspirin,
That's a
okay?
lie.
They don't let us try them.
Okay.
Transmitting a second 12 lead.
You want to do blood?
I'll do it whenever we get closer.
Okay.
Yeah.
I keep wanting to check my radio.
I'm probably gonna
Shows you
start
how
doing
far
that
you
on the
really
way
were out
too.
because you had no radio signal, so that's okay.
Not a difficult feat in the county.
Stick right here. 1, 2, 3.
Good, you're kidding me.
When you're doing this IV, did you think it was going to be broadcast on
No.
the internet?
I didn't. At least I got it the first shot.
There
So,
you go. Strong work.
Thought that was one of those locks.
Yeah, no, only the 20 gauges.
If you would have missed it, Jeff would have done something with AI to make it look like you made it like one-handed.
Well, you'll see here in about 45 seconds. That's not the worst of our worries.
Keys in his lock.
Thank you, sir. Got your wallet, your phone, and your keys.
Thank you.
Okay.
Any changes in the ST elevation or anything like that on the back-to-back 12 leads?
Not without having to look at him again. I don't remember anything significant being different. He was pretty consistent until he
I'm
wasn't.
ready to
Yeah.
go whenever you are, Rusty.
when we reviewed it,
I'll be able to do everything else now.
then I didn't notice anything dramatic.
Yes, sir.
His blood pressure's been holding stable.
It'll be your discretion. If it's open, then we don't need to run code, but if we get bogged down, we'll upgrade it.
That changed.
There goes 130.
Thanks, sir.
Mind tossing that over there.
I don't mind at all.
So does fire leave prior?
Thank you.
They're fixing to. There they go.
There they go, and then here goes Rusty. Yeah, I think
I get to the door.
and look, VFib right
Oh
there.
my gosh.
Hang on a second, Rusty. You okay? Call him back.
It's not okay.
Come back.
You okay? You got a pulse? Is he gonna be
He's still blinking.
Yeah. He's moving his. There he goes.
Got it.
I got it.
You want 800?
There's no 800 around here. They're both in Weatherford.
Doing something important, I'm sure.
You mind helping move the monitor to the seat?
Probably a podcast.
Yeah,
Probably
it's
throwing
probably
it
what it
up
is.
podcast.
Get on the radio, say CPR in progress.
You can hear him grunting there with the compressions.
So he never really went unconscious. He just went into VFib. You got on the chest
I
immediately.
saw that V-fib right when his eyes rolled back.
Good job moving the monitor to where everybody can see it.
You guys are pretty darn calm. You're making me uncomfortable. You're so calm.
Okay, Rusty. You're gonna have to get these 12-lead cables out from underneath them.
So this is where having the pads on would have been good.
Absolutely.
Right?
Yeah.
Pull them hard.
And that's a change in practice since then.
Yeah.
For me.
Yep.
Not yet. I don't want to give up. I don't want to give up all that room. Okay, ready, Rusty?
They asked about the Lucas. I said I didn't want to give up any room for the Lucas.
Okay. You mind getting his arm? We'll roll
And it doesn't
my way
affect
for the
survival,
pad.
so
Isn't what?
it doesn't affect survival rates.
No.
I wanted to prioritize as high quality compressions as we could.
Yep.
And I knew that we were indicated for an immediate defibrillation.
Okay.
See, and you can see he's resisting because he's conscious. But he doesn't remember any of this.
Good.
That was interesting.
All right, move over to pads. Yep. Up top. Okay. Charge.
I don't want to lose this.
Okay. All right.
Clear.
Hang on. Watch. Wait. Look at it. All right. Hit him. Compress for me.
Just in case the compressions had converted him. Yeah, you never know.
So I mean, good job switching compressors at 2 minutes, right? We all say we're good, but the quality compressions, the depth, the adequate recoil goes away after 2 minutes. So
Get the ammo out.
stressful situation, good job doing that.
Well, being the lead of the call, looking back on it, I wish I would have given up the compressions earlier. That way I can step back to run the call.
Yeah, but it's tough in the back of the truck. You have limited space.
Yeah.
And actually, the rates are pretty good. This is a little fast, probably. So metronome added in there. We're typically doing all of our calls.
There you go.
There you go.
Perfect.
So watch him slow down now, probably.
No.
See him slow down?
No. We'll do 2 minutes.
He's probably going like 130, 140. Yeah.
Yeah.
So remember the life pack set at about 102, so you want him to be a little bit faster than life pack to kind of keep it around 110, which really sets you between the 1 to 120. You can see now he's dead on, and initially he was probably a little fast, right?
Yeah.
Oh, we need to drop an eye gel too, I guess.
So you remember the airway, and there's obviously a delay in ventilations here. You guys were busy. However, you also had a guy that was conscious up through most of it, right? So
Yeah.
you don't think initially like, hey, I just got to throw an airway in this guy who's
Probably a
blinking.
4.
Right.
So
And we also found out when I went to go put the airway in, he was clenched.
You can see I'm not getting past his teeth very well there.
yep.
Like you couldn't.
Yeah, I think that's a very reasonable delay. I don't think we've been delayed that much in here, especially with the
I've
space,
got about
and
20 seconds, so go ahead and pre-charge.
it's tough in the back of the truck.
Yeah.
And so far, I think we're running everything on my watch. I don't think we have a dedicated timer yet.
As long as you know where it is, that's all that matters.
Okay. I'm ready whenever you are, Rusty. V-fib, hit him. All right.
Have you guys given the ammo yet?
No,
Okay.
so I went looking for the ammo in the wrong box, just coming off the chest.
Yeah.
I didn't think about it. And the darndest thing is I found a vial of ammo in the
He
box
changed quick.
that
Right.
shouldn't have had
The
ammo
action
in it.
wall box.
Yeah.
Yeah, so I was looking for the rest of it, and you saw I got interrupted because Rusty called for suction,
Which is important.
which is, yes, the priority. And then we suction.
Clenched.
Rusty's trying to get that eye gel in. And this is where he starts to,
Oh, he's blinking. All right.
yep.
We're taking care of you, Terry. No.
So 2 shocks so far?
See right there?
He wants to
said-
stop.
He said, wait, you want me to stop?
Yep.
No.
Yes, 2
That's
shots.
a
sped up
weird,
again.
that's a weird thing
Yeah,
to
so
do.
little things here. He obviously, whoever's
off.
leading the call could say, hey, go with the metronome, slow down, right? And then probably switching that compressor after that second shock. So little fine-tuned things when we look at it, Monday morning quarterbacking, but obviously limited space, hard to get somebody over there. It's not a room where you can get somebody behind there.
We have a pulse?
So he was in VTAC
Yeah, we got a
briefly,
pulse.
and then
He's looking at
went
us.
back down to VFib.
Yeah.
So he had a pulse with VTAC there?
I wasn't able to feel a pulse.
Okay.
The VTAC was very transient. He was only in VTAC for a couple seconds.
Wow.
Hang on, let's see what he got.
And if you heard him there, I said,
Yeah.
somebody said, hey, he's awake. And he said, yeah, I am.
I got a strong
But
pulse.
it was definitely V-fib whenever we hit him that time. But now we're
Contact,
sinus.
Ross. Okay.
It's awesome.
Blood pressure, manual blood pressure. There you go.
Manual blood
You okay,
pressure. I
Terry?
love it.
Okay. How you feeling,
Yeah.
buddy? Okay. Okay.
Yeah, he just,
All right,
oh my
you know where you are
gosh.
right now?
Yeah.
He says
Where-
okay. That's
Okay. So remember earlier I said I didn't want to freak you out? Yeah. Well, I still don't want to freak you out, but your heart stopped for a second there, buddy. So we got you back, but we're getting you checked
He's
out here.
patting
Okay.
his face.
All right.
Stop for more than a second.
No need to freak him
4
out.
minutes.
Okay, Terry.
Yeah, now we'll take a rider.
No, actually, I don't feel too bad. Okay. Maybe you got out of your system for us then, huh?
Yes, sir.
It'd be hard to explain this to someone without the video. I mean,
Absolutely.
Wait, hand me those ears so I can get
that is insane.
What's your name?
Seth.
Seth? Okay, Seth. My name's Connor.
He said, I don't feel too bad.
Okay.
Yeah.
Yeah, and he'll say that on the repeat. He says, actually, I feel a lot better.
Yeah, he
so I
does.
think another really cool thing here is you really see the interaction with fire and EMS, and it's not the way it's always been. And certainly we've been, fire side and EMS side, been working really hard in this collaboration for the last 5 or 6 years. And so the fact that everyone knows what they should be doing, everyone knows how to work together as a team, and you just, meeting Seth for the first time, he's riding to the hospital with you, so that's the trust and collaboration we have between fire EMS and the county, and that's just amazing that we've built that.
I love that you
It
guys
is.
got his heart started again and then just immediately started transporting.
We already had everything set up.
Yeah, but I feel like in that situation, I'm going to just sit there kind of breathing for a minute at least. And I don't know.
Well, Rusty and I are big on, if there's something that can be done on the way to the hospital, our plan before he arrested. Let's pop this IV in. I can do my reassessments while we're going towards the cath
Blood
lab.
draw and
Yeah, get blood drawn when we get closer. And I think I do get blood drawn when we get closer. But I have a rider, and we have everything in place that.
So this also really shows that we all know the two most important things, the two things that have been proven, the only things have been proven to save a life in cardiac arrest are two things you guys did.
Mm-hmm.
Early defibrillation, high quality CPR, early CPR, high performance CPR, everything that the Resuscitation Academy talks about, right? No epi, no bicarb, really no amiodarone at this point, right? And that's why this patient survived, because of focusing on those two things in a really, really stressful situation.
Waking back up and saying, I feel okay, actually, is just, after he was dead for 5 minutes, right?
It's remarkable. Yeah, 4 to 5 minutes. So what else goes on en route to the hospital then?
I think I just get serial EKGs. I get secondary IV access, which we saw Rusty's. We don't have to see mine.
Okay.
And that's about it. Obviously, reassessing his mentation and all that, but nothing changes.
Any meds on the way to the hospital?
No, I think I pulled the protocol to see the exact verbiage on our amiodarone post-arrest protocol.
Right.
And the verbiage to me was if amio is giving during the arrest, and then we give a maintenance dose or a drip.
So in this case, the fact he was in it, you kind of like to keep him out of it. So you could give 150 milligrams slow push over 10 minutes, or with the pump, we would typically do in the hospital milligram per minute, right?
Mhm.
So the goal is to keep him out of that. So give him an antiarrhythmic to hopefully prevent this from happening again until we get his vessel opened up. So if I see this guy come through the hospital door, I'm going to probably give him 150 milligrams over 10 minutes and probably continue a drip in the cath lab until you get his vessel opened.
Sure.
So that's a little fine-tuning stuff as well. But the whole idea is to keep him out of that. You don't want it to happen again, right?
Yeah, and that was the quickest arrest that I've ever had. I've never had an arrest that we didn't get a chance to give amio to.
Yeah. So when you talk about epi with this guy, right? So when you look at AHA's guidelines and you look at some of the new stuff that's come out, is when we look at all these PIG trials for the Resuscitation Academy and for the ROC trials, is in AHA, they give a bunch of epi to put people into a shockable rhythm, right? So you already have somebody that's in a shockable rhythm. Epi really should be pushed down the road, right? So now the new requirements and new recommendations are after 2 shocks, and that's what we do here. But certainly not focusing on epi in this guy. Focusing for sure on what you guys did, and then adding amio would be the perfect scene. But I mean, this is an amazing case, and it's really fun that we get to watch it and kind of see the care delivered, and really go through little things that we could change. But ultimately, this is what we want to have happen. And great job for our telecommunicators, too. I don't think that there's enough agencies that really stress how important telecommunicators are for patient care. They are really in charge of our patient care until we get there, and we have very long response times. And so we talk about this on cardiac arrest calls, but especially this guy, just saying, hey, let us continue, let us check you out. His outcome would be very different. So, a big plug for telecommunicators out there. They're a really important part of, talking to our patients, getting them prepared to let us in the door, hopefully getting someone on the chest, getting an AED found if it is a cardiac arrest prior to our arrival. They're a massive deal to our continuum of care.
Rusty, while the cameras were off, you were just talking. Why don't you go ahead and say what you said again about pre-alerts?
Well, we were talking about the telecommunications, and we know that without her doing what she did, this call would have been way different. But also because we have pre-alerts, and Connor and I generally try to get out as soon as we can. So we were almost to his house before we actually got dispatched. So just pre-alerts really help us make sure that we're on top of getting to the call in a timely manner. And in this case, we didn't know what was going to happen, but
Sure.
because it happened the way it did, it just made it all work perfectly.
Yeah, so our pre-alerts work as soon as they get the address. When they get the address, it assigns, it tones out as a pre-alert. We're not really sure maybe even what's going on at that address yet. Certainly don't know if it's going to be priority 1, 2, or 3. So our priorities, priority 3 just gets you an ambulance, no lights and sirens. Priority 2 gets you lights and sirens, fire with ambulance. And then priority 1 gets you one of our 800 supervisor units or physician vehicles along with fire and EMS, all priority, all code basically. So just hearing that pre-alert, I mean, that could be a minute or two before we're figuring out what's going on. And we're heading out the door, getting the truck rolling, start heading that way, which I think makes a big difference on these patients, especially this gentleman.
Absolutely. I want to go back and watch the moment that he starts actually getting really good circulation back, because Connor, you were saying he actually talks. So I'd like to just hear that real quick.
There you go. Oh, he's blinking. All right. We're taking care of you, Terry. No. Keep going.
You'll see if
Ventilate.
he's awake. He's
All
awake.
right, get the charge ready. It might be a conscious CPR. You're okay, Terry. We're taking care of you, buddy.
We're good right now.
Yeah, get ready to swap him out. This is the second round. Okay.
You got 1 minute.
VTAC, sync it. We have a pulse? Yeah, we got a pulse.
Okay. He's looking at us.
Yeah.
Oh, he's talking.
Yep. Sync it. All right, hit him. Hold it. All right, hang on. Let's see what he got. Okay, I got a strong pulse. Mark that. 21 times St. Ross. Okay. Blood pressure, manual blood pressure. There you go.
We've seen the rest of this. Manual blood pressure, fantastic. So there was a bit of a delay there. I mean, it wasn't the fastest defibrillation I've ever seen.
Well, I think they were determining whether or not there was pulse or not,
Exactly,
right, which would
yeah.
have changed. And you got to hit the sync button. You got to make sure I mean, there's a lot of changes that go on, but as soon as you saw what it actually was underlying, and sometimes the rhythms that go kind of back and forth where it gets tricky. And remember, we're not great on hypotensive patients feeling a pulse. That's why we started incorporating more color Doppler with ultrasounds and stuff like that as well. But still, absolutely amazing care. And then to talk about conscious CPR a little bit more, we had to add that as part of our protocol a few years ago, where we used ketamine during conscious CPRs, because we've been having a lot more of these really throughout the Best EMS system. And these patients were really fooling the brain with our high quality compressions, and we're starting to get sugar and starting to get blood flow and oxygen to the brain, where the body, the brain is basically confused. It really thinks that it's working, right? So we stop compressions and the patient goes back unresponsive and has no pulse still, and we start back up. So we're really tricking that brain. And we've had a few of those, recently over the last couple of years that we've actually had to give ketamine to, because every time we stop, we had no pulse, and we start compressions again, and they start yelling, trying to sit up, trying to talk, and we obviously don't want him to remember. So does he remember anything with this? Do you guys?
He remembers the last defibrillation.
Okay.
Yeah.
Where he said "ow."
Yeah, where he had a big ow. Yeah.
I think I saw one of the firefighters. We were saying he was going a little fast on CPR. I think maybe a normal CPR, he slows down a little bit. I'm guessing that's the first time he's ever done compressions on somebody that's looking at him, and that's. I mean, I've only done it.
It does change.
It changes your adrenaline level a lot. Like, he's probably wondering if you guys know what you're talking about, and he's probably wondering, what the heck is going on. As I was the first time I ever did compressions on a conscious CPR. That's an unsettling feeling. So let's talk about the guy's outcome. So Terry, first of all, huge thank you to you, Terry, giving us permission to watch this video, to review it for our purposes. You're allowing us to put this video out and show it to the world so that everybody can learn from our mistakes and learn from our accomplishments, because that's what this call is. This is a huge accomplishment for somebody to have an out of hospital arrest and have no deficits, immediate return of spontaneous circulation, rolling into the hospital awake. That doesn't happen, and it wouldn't have happened without Marita convincing Terry, hey, you really do need us to be there, and it wouldn't have happened without you guys getting on this guy's chest and early defibrillation. So, Terry, thank you so much for letting us watch this video.
I appreciate it. And I don't know if you guys realize how powerful it is when you watch a CPR save watch their video for the first time. We did this with a save who's spoken at our Resuscitation Academy a couple different times. He was from DFW Airport, and he actually was going to do routine business travel, had gotten out of a vehicle, I think an Uber, and basically arrested. And we had all the PD body cam from there. And of course the officer shows up and he's very excited. He's grabbing his AED and he gets up and there's not an AED on the guy, right? And there's another AED beside the guy, because at the airport we have TSA and we have police and we have fire and we have all these folks that grab AEDs, and there's over 500 of them. It was really powerful. But I remember we planted him. We didn't tell really any of the people coming to the RA that he was going to be there. And so we showed the PD body cam, showed him getting compression, showing us get ROSC, and then we shut it down. But watching him, he was tearing up the entire time, because that was the first time he had seen basically himself dead, getting CPR from bystanders, TSA, PD, and fire, and basically coming back to life with a pulse. And he was bawling. And then we got up and said, hey, since his name's Chuck, he's pretty open with the RA and open with us and speaking. But I said, this is Chuck. And Chuck got up and it was extremely powerful. But that was the first time, is when we invited him, that he actually saw the video of someone doing compressions on him from that day. And so I'm sure Terry, very much of the same. It's going to be a touching for him, to watch it and watch the care and hear us talk about it. But we can't learn from these cases. We can't teach, to the power that we want to teach without people allowing us to show this.
Yeah, and I'm assuming Terry had a good outcome. He got catheterized. Everything was good.
Yeah. Should I share the outcome that he gave to us? He came to the station and shared his outcome with us. Do you think
absolutely.
The last time we got to talk to him, his cardiologist gave him a clean bill of health. No CHF. His ejection fraction was like in the 70s, or
78 was
it? Something like high 70s. So he's getting taken off all of the meds that he got. Like, the only thing he's back on is his blood pressure med. And getting to talk to him, he's really appreciative. He's a great guy. He has a great family too.
That's fantastic.
Well,
go ahead.
What stands out to me on this whole thing is that right after we got back from a different call, there was a girl waiting for us. Come to find out, it was his daughter. She came to the station just to thank us because she was fixing to go on a trip. But I think the one thing that stands out to me that he told us early on was after all his stay in the hospital and all his care, he was driving back home early in the morning, and he said it was the first time he saw a sunrise like that. And
I bet.
I don't know about Connor, but for me, that makes everything we do, even the hard stuff and the frustrating stuff, all worthwhile, because he said he saw the sunrise for the first time.
Yeah.
Right. And I think Connor, they follow each other on Facebook, this patient, and I have a couple other saves that we've had, and it's amazing to see what they post with their birthday, their next anniversary, their grandkid, their trips. And when you think about it, some of these people have been following for 3 or 4 years. They wouldn't have had any of these memories. And so it's super important to follow your high performance CPR, to keep training, to keep doing what we're doing. And I think the calmness, while still having urgency with this call, watching it actually makes some people feel uncomfortable because you guys were so calm. This is something when it happened, you're like, holy crap, this is happening, right?
Oh, we were thinking that.
Yeah, I know you were, but still very calm, still trying to hit all the benchmarks, still trying to do all the right things, still trying to switch compressors when it's incredibly hard to have that many people in the back of an ambulance. There's not much room. It's hard to switch. It's not like a living room, right? And then he came up and signed our airplane plaque, and so hopefully at the end of the podcast we'll put some pictures of that. But he picked a seat on our airplane, and he's one of our CPR saves. And I think we're getting to the point, at least in our region and Best EMS and PCHD, that we are now expecting to get these people back. And if we don't, we feel like we did something wrong. And this would have been a very tough case if he wouldn't have survived, because I think you guys would have felt like, man, what did we miss? What they focused on in a very urgent manner was good compressions and shocking.
Yeah. So. And that was something I was hoping. I don't know if are we going to do like any more clinical debrief or anything?
I don't think so. I was just going to touch on basically the fact that almost anybody can do what you guys did with an AED and good compressions. But if you want to say something else.
Well, I was just going to open up to everybody else's. Were y'all's alarm bells ringing, seeing him in the living room and go, oh man, this guy's going to arrest in the next 3 minutes?
I didn't need an EKG.
I knew he was having a heart attack, but
I think the big take home that a lot of young medics need to understand is, and I was on a call not too long ago where there's somebody that was anxious and they were diaphoretic, and there's, oh, she's just anxious. You can't get anxious enough to make yourself diaphoretic. So something else is going on, whether it's a blood sugar issue, right? Hypoxia, GI bleed, MI, right? When you get diaphoretic and you're not outside in 100-degree heat in Texas, something is going on with that patient, and you got to dig deep. And especially with your diabetic patients, we've had a few 40-year-old diabetics, 0 chest pain, having massive STEMIs. Mm-hmm. So when that patient's diaphoretic or that patient's really nauseous, your elderly patient's just nauseous, get it 12 lead, get it quick, get it within 5 minutes. But man, it is really scary to have a 40-year-old diabetic that you do a 12 lead on. It's a massive inferior STEMI, and they had 0 pain, 0 arm pain, 0 chest pain, 0 jaw pain, massive STEMI.
I want to say something about the calmness is due to our training. That's one of the things I would like to note in this, is that because the way we do things now, we train for what we could go on, and that helps us, Connor and I, be calm and do what we know to do because we've trained at it. And that's a difference from when I started in EMS till now, is that training is phenomenal.
You're 20 years in. You're not supposed to be excited about training.
I am. Connor, I just wanted to let you know that I have had a very similar situation where somebody went into ventricular arrest in front of me, and I did not have the pads on. And the next 30 seconds was terrifying and felt like I was moving in molasses. And that sticks with you. When you have somebody do that in front of you, you'll never let it happen again. It's one of those things where, you know what, I'm going to waste a set of pads every couple of months.
Yeah, we talked about it during the break. I used to not be a pad placement guy, and I thought I had some semblance of a reason why. No, all of my STEMIs are now getting pads placed.
Yes,
absolutely. Yeah, we don't like the woulda, shoulda, coulda done.
What would be more embarrassing is if you didn't have pads in the monitor when you went to grab them.
So thankfully we had that much.
Yeah, so that makes you want to check out the truck even better, right?
Yeah, the last 4 stickers were a problem. The pads are not.
So the last thing I'm gonna say before we wrap up here, guys, is just the fact that this call went so well, and you guys never even got to the advanced stuff. You never had time to get to the advanced stuff. You're heading that way. You're getting the iGel, you're getting suction. Like that guy, Terry stays in arrest for another 5 to 10 minutes. He's going to be intubated. He's going to be sedated. All of those things were happening. This kind of thing can happen with just a couple of bystanders and an AED. This level of care could easily happen with somebody just having taken a CPR class and having an AED handy, they could have had this exact same outcome. And a lot of our arrests that have really good outcomes, that's really all it is. It's just early compressions, early
BLS first.
Yeah.
So Seattle proves that to us. RA proves it to us. I mean, this guy, if Marita wouldn't have done what she did, this person would have been probably a DOS code white signal, right?
Yep.
So
whenever
great,
most definitely.
Great training, great job from everyone, great compassion, great urgency while still staying calm, and that's what we try to do.
I may have to work into my next STEMI telling them they're having a heart attack the way Connor told Terry. he was having a heart
Got
attack.
good news and bad news.
Yeah.
Yeah, this is actually pretty light on the Connorisms for the call.
That I would agree with that.
He loves his Connorisms.
Yeah. Do you guys have anything else before we wrap up?
No, just appreciate the opportunity.
Yes,
Appreciate
yes.
Terry, and glad that he's doing, at least last we talked to him, significantly better.
Absolutely.
And to talk about body cams, man, I mean, everybody, especially old school like me, wanted to resist them.
Yeah,
but
me too.
This proves why it's important.
Yeah.
And
It made the chart easier to write, I'll tell you that.
Absolutely. Yeah. It's hard to learn if you don't know actually what happened. And
Yeah.
I've noticed a lot of times you don't really remember it right. So, thank you guys for joining us.
thank you.
We're gonna hopefully have more of these coming up. And this was a good one. And Terry, one last time, thank you so much for letting us
Yeah, most
review this
definitely.
video.
Thanks, Terry.
Thank you guys
Appreciate
for
it,
joining
brother.
us.
Thanks, y'all. Bye-bye.
Bye.